without further ado, I'm Mike Biddle, and I'm the host, and that's my popcorn, so I'm going to get that later. So I'm just going to talk you through some of the stuff we've been doing, or how did Dallas come about, why are we here today, and then we'll hear about the people who've actually been doing it. So I was involved with Dallas from the very, very start. So I'm now Deputy Director for our Innovation Programmes activity at Innovate UK. We're very much about trying to accelerate economic growth. We recognise that if you're trying to rebalance the economy, and the government says that's what they're trying to do, then you need to do things differently. If you need to do things differently, then you're going to need to innovate, and that's where we think we come in. And what we're trying to do there is think about how are the challenges that we as a country face, the public sector, the private sector, how can you take that forward? How can you communicate that to UK businesses so that as well as overcoming the challenge, we can actually have a business, a vibrant business community in the UK that can to address those challenges and then export globally. So Dallas was one of those where we kind of thought things come together and we can actually really, really make a difference, but also help UK businesses. And that's what some of the evaluation stuff was around, which is, you know, helping all sectors and all parts of the community. Now, Dallas has been a bit of a journey for me. I've not been as connected with it over the past couple of years, and that's, you know, we'll hear from Hazel and the team who have been there. But it's kind of, at the time, it was very much a passion in terms of getting things going. And it brought together two parts of my life that were quite important. So one was actually football. There was a theme of football to start with, not intentionally, but it turned out that we came to Manchester pretty much 4 years ago to the day. I think it was 2011. I think it was probably something like November the 20th or something like that. And we were at the Etihad Stadium. And the reason for that is we had so much interest, that was actually the only venue that could actually cope with us. At the time, Graham Worsley, who was working with us, he's a Manchester City fan, and he couldn't bring himself to go to Old Trafford, so we went to the Etihad. And interestingly, the Etihad actually had a capacity of about 50,000 people, and we were there, and we said, well, you know what? We were, at the time, trying to find 3 to 5 communities to help people live more independently for longer, and 3 to 5 of about 10,000 or more, 50,000. So the logic actually was, in theory, how do you fill that stadium? How do you help people around the country but be able to fill that stadium? Now, you know, along the road, you know, we've learned some things. We've learned some things that did work. We've learned some things that didn't work. And that's what today's all about. That's what the roadshow's about, which is how do we share that? Because it's not just about saying, you know, everything's been great. It's about helping people understand what didn't work as well, because then we can all move forward from that and not do it again, or understand why it didn't work and fix the reason for why it did. So in terms of passions, the other one actually is film. Now, I don't think Hazel knew this, or the team knew this when they picked the venue, but film is one of my passions as well. And I was involved with the Film Society when I was at university, and that's how I know the Mr. Sands thing, quite a few different bits and bobs. I used to be the guy at the front actually with the tray of ice creams, which was, you know, was a bit retro, but we did make quite a lot of money from that actually, which is quite interesting. So then I started to think, well, what are the film references for Dallas, and maybe what would that look like? Now, first thing that sprung to my mind was Debbie Does Dallas. Probably not the right reference, actually, so I quickly moved on from that. And then 13 Days, actually. So 13 Days was a film starring Kevin Costner about the Cuban Missile Crisis, if you haven't seen it. And the reason that sprung to my mind was JFK. So JFK, right in the middle of the Cuban Missile Crisis. And some of you have heard me talk before about the fact that, you know, 1969, landed on the moon, and that was about the time when actually all the baby boomers were born. So baby boomers sort of 1946 through to 1964. So by the time we landed on the moon, all those baby boomers that we keep talking about in terms of demographic change, they were already on the planet. We knew they were here. You know, it wasn't a surprise. It's put some of the people in this room. But the interesting thing about JFK is, you know, he did say that, you know, we choose to do this when we were launching the moon program, not because it's easy, but because it is hard. And if anything, the one thing I've learned, and we knew going into Dallas, is that it was going to be hard. So that was my first reference. I then started to think, well, what about the good, the bad, and the ugly? And I think that actually gets to the evaluation piece. So there will be the good, there will be the bad, and there will be the ugly. And that's fine, because we should just learn from it. So let's use these sessions today, use the information that's going to be on those portals when you follow that QR code when you're home, and you can book it in your diary now. So if it's going to be there on the 10th of December, you can put it in your diary, you can keep your microwave popcorn, and then you can sort of put it at home, put that in the microwave, and then look at the material that's online. So let's learn from that, because it is going to be important. And then, actually, what I started to think about, what about transformers? You know, that's what we're trying to do. but then I kind of thought, yeah, maybe that's a bit too sort of high tech and all CGI, and and there's no real story content, is there, to the Transformers? So for me, actually, probably the one that I was thinking of is actually The Artist. So I don't know if you've seen that, but it was an Oscar winner, so it has pedigree. And The Artist was all about that point when film started to become talkies. So, in the 1920s, wasn't it? So until that point, we didn't have sound in terms of, it was somebody down the front playing the Wurlitzer or whatever. And it was a big change for those players, both the people, us as people watching, as consumers of the content, and I think, we are going to be consumers of these services. It was a big change for the industry. And they were making a big change. It was also then a big change for the people involved with that industry. So those actors, all of a sudden, before they just needed to look pretty and act but not be able to speak. And some of them didn't necessarily have the best voices for them being able to be recorded on film. So it was a change for them, but they went through that change. The other takeaway from The Artist, of course, was the dog became very, very famous. I don't know what the equivalent for Dallas for that dog would be. But so for me, it is about the fact that we are going through a change. I think whenever we look at the independent living sector, and we've been talking about this now, so we got involved as Innovate UK, formerly Technology Strategy Board, in sort of 2007, 2008, and it's always felt like we're nearly there. But I think you can start to see now that actually some of the bigger political drivers, and we heard about Manchester this morning, do actually start to change that landscape. So what we need to think about is, as that landscape's changing, and with the work that we've been doing over the past 3 years, and it's not just about what's been going on in Dallas, it's about the stuff outside. How can that all come together and be part of that transformation and that change from just being black and white and sound and Wurlitzers through into talkies and through, if maybe we're going through into talkies, when does colour come, and who knows when does 3D come? What does that look like? But, let's not get ahead of ourselves. Let's just recognise that maybe there's a bit of a transformation. So we need to think about all those things. So as we go through today, I'm going to be interested to hear about what's going on, what we've learned from it, what has worked, what hasn't worked. I think we're pretty much on time. So what I want to do is introduce our panel before we actually then get into the film about some of the stuff that's been going on, and then we'll have a bit of a panel discussion. So going round, so we have Hazel Harper, if you haven't met us, who's started out actually as a Dallas delegate, and liked it so much, she actually joined the club and joined the Technology Strategy Board and now Innovate UK. John Eaglesham, Andrew Chitty, and then who will actually lead us through for the panel questions in a moment. Dave Horsfield, Lindsay Linton, Frances Mair, and Karl King. So they're the experts for today. I am as interested as you are to hear what they've got to say. So without further ado, we'll listen to the film and see some of the transformation that has been happening and what we can learn from that. Thank you.
Dallas was designed to be different, to test whole system change rather than technology. The programme started by bringing usual and unusual suspects together in a sandpit. The sandpit encouraged the Dallas contributors to incubate multiple ideas, and from these many seeds, the 4 Dallas communities were selected. 2 were defined by geography, living it up in Scotland and more independent in Liverpool, while Year Zero and iFocus looked at issues that could unlock digitally enabled assisted living services everywhere.
The original idea behind iFocus was to pull together a collaboration of different types of organisation to address the problem of interoperability in its widest sense. And interoperability was seen at the conception of Dallas as being one of the main reasons, the main obstacles to widespread adoption of digital technologies within the healthcare system.
The assistive technology part of More Independent allows us to see that you can keep people out of hospital with the use of technology. It was a great kind of altruistic aim. Well, in this city, we've proven that you can do it by rolling out this kind of stuff at scale, based on clinical pathways, not based on boxes and gizmos, but based on where that clinical need is, where patients may benefit from it.
So that's apps, online products, but it's a programme with a difference. It's not your usual NHS programme in that it involves a wide range of partners from industry, partners from the voluntary sector, partners who provide services, but probably most importantly, it's a partnership with citizens in the city.
The original idea behind Year Zero was to put the citizen right in control of their own data. That enables them to manage their interaction with health and care services, whether it be hospitals or primary care or local authority and social care.
To actually demonstrate the concept of personal health records and actually how the individual can input into those records themselves, we developed a series of products that included a personal health record called A Better Plan and a secure social network called Good Neighbours. We developed the e-Red Book with a company called SiteKit, the digital version of the paper Red Book that's given to new parents on the birth of their child. In the later stages, we developed the e-Day Book, which was a management record for domiciliary care providers.
We had an idea, how do you recognise people as assets living in the community and pull those assets through in a way that helped them to support their own health and well-being? Living It Up today is an online service.
It's a website that's designed to help over 50s in Scotland to use technology to manage their health and well-being better. But it's got quite a broad reach in that we're also helping people to connect better in the community, have better digital skills, and so it's not just got a health focus.
We've got 4 main sections to the website. One of them is all about encouraging people to be able to give back and make use of their skills and the things that they know that they're good at. We've got a section on the website called Discover, allowing people to discover what's happening in their local area. And then we've got Connect, using technology to connect to other people. So we look at things like Skype, video conferencing, using social media. And then we've got a big section of the site that's really more health and care focused called Flourish. There's lots of digital tools and trackers to do things like track how active you are, how many steps you take.
For each of the 4 communities, the individual, be they citizen or patient, was placed at the heart of the new system, with redesigned health and care services around them. 6 high-level design principles, known as the 6 Cs, were adopted by Dallas to embody the changes the projects were trying to bring about.
Of the 6 Cs, Liverpool's kept at its heart connectedness, so being connected to our clinicians, being connected to our citizens, another couple of Cs, and that's led us into co-design, but also being able to collaborate, and not just collaborate with delivery partners, but being able to collaborate with citizens in terms of understanding their challenges, but also understanding their aspirations for health, their aspirations for technology.
The idea of connectedness was clearly central to interoperability, and this idea of connectedness of information, for sure, but also the broader idea of how you're creating a channel to connect people to professionals and to informal carers.
How does choice translate into what you're trying to do with Living It Up? And that was looking at things like, well, choice would be a menu of services. It wasn't just about, kind of esoteric theory. It was, you translate that into very specific things that you then had to go on and deliver. So community wasn't just the concept of community. It was very much about building an online digital community and seeing people as equal participants within that as well.
Converting those 6 Cs of control, choice, community, connectedness, contribution and collaboration into practice meant each community surmounting the problems of deploying new services in a live and dynamic environment. This threw up new challenges for the projects and their users, both professional and public, but also provided some key lessons for those tasked with evaluating the impacts of Dallas.
People say that Dallas is different, and I think that's very true, because it's completely different from the kind of randomized controlled trial, very controlled environment from which most academics are involved in evaluating. And I guess from our perspective, one of the biggest learning points in Dallas is about how do you learn how to deploy digital health technologies at scale. What are the real life challenges? Because so often we have randomized controlled trials, we look at what goes on in those trials, and they then, when the trial is finished, they may show some benefits, they may show not disbenefits, but if they're beneficial, they often don't roll out and become real services. So Dallas was about real services being delivered to the public at scale. And that's never been done before anywhere internationally at the scale of Dallas in terms of the range of services being deployed and the numbers of people that were being approached.
The biggest challenge initially was cynicism on behalf of clinicians. I think that we'd been told by the government for many years that telehealth was the future, and the evidence was pretty poor, and we'd never yet seen a programme that had demonstrated real change to the patients that we see every day. And so the fact that we were able to organically grow that in Liverpool and win those hearts and minds was critically important.
One of the big challenges that kept coming up throughout the project was the area of information governance and data control and who owned the data. And in the case of the Red Book, it was a particularly pressing issue, I guess, because we had the product at quite an advanced stage of development. And whilst we were piloting it, the partner organisations were quite comfortable with that. But for any kind of wider deployment, they needed to know that they had the backing and approval of a wider authority, if you like, in terms of what could be allowed.
When you break it down, what you get to is the fundamental point that we want people to self-care, we want people to live independent lives, healthy lives. It's about them. So you've got to give them the ownership of their information and access to a variety of different means to give them choice about how they wish to do it. Self-care, self-service is not within the DNA of the NHS. It's not within the DNA of practice. And that's translated through to citizen expectation of the NHS. Citizens expect services to do things to them.
To use digital technology successful in healthcare, you've got to take a step back and you've got to take a service innovation design approach. And by that I mean you've got to look at how you might do things differently. Healthcare is looking at continuous improvement in many cases, but there's a limitation to that improvement. At some point you've got to do things differently. You've got to find different capacities in the system. And in healthcare you've got a capacity that's almost unused, which is patients.
One technique all of the project found beneficial when it came to identifying ways to do things differently was co-design.
With Living It Up, we really wanted to use co-design as the methodology that we would go out and make sure that we weren't just designing something that we thought people would want to use, that we were actually designing something that came from the community. I think that there are, certainly in the co-design process with Living It Up, there were a lot of people across Scotland living with all sorts of different conditions who were really engaged and really keen to manage their own health more. So I think there are lots of people who are ready for it. I think there's lots of professionals who are ready for it as well. But it's not everybody.
We've worked with some champions of self-care who see the promotion of self-care and helping people to help themselves as being at the heart of certainly primary care.
Our lead clinicians stopped asking about the evidence base because they'd heard citizens say that technology and self-care makes their life easier.
There are perhaps two different types of technology-enabled redesign of services. Now, one of them, typified by the Red Book, is where you're closely aligned to a clinical pathway. You need a solution that needs to be worked through from end to end. Once you have worked it out, there's no reason why that can't then work on a national scale. Now, on the other hand, what we found with access to primary care work that was carried out in Birmingham with Vitality Partnership is something quite different. There, 60,000 patients, within probably a month, we had 3/4 of people using the service because the digital access model really, really worked for them.
Get your clinical champions early, keep the models very, very clinical, and keep at it. There are naysayers out there abound who will tell you that it's a flash in the pan. We've proven that it's not. And so a dogged attitude to continue with what you believe to be right for the people that you're serving would be the best advice.
I feel like there should be a round of applause after that film, but okay, fair enough. I asked for it. So lots of thought-provoking things, hopefully, in that film for the audience. And what we want to do in this session, it's a panel for a reason, so we want to run it a bit like question time, hopefully. So we do have, or at least I have, some themes that I've picked out of the film that I want to invite the panel to elaborate on. But what I will do is then pause and invite some questions from the audience, so please get your thinking caps on, and if you do have a question, there is a roving mic somewhere. Somebody's waving over here. So have a think about what you saw in the film and have a think about what you might want to ask the panel members. So there was a lot of talk about 6 C's, and I think there was a few extra C's that were creeping in. So I'm going to start with what I think sounded like one of the extra C's, and that was around the co-design and sort of throwing an extra one in there about citizen involvement. And maybe starting with Lindsay to begin with, because Living It Up highlighted that in the film there. What was the role of co-design, and what was different about the way that you approached it in Dallas and in Living It Up? Because a lot of people sign up to co-design but don't really know how to do it in practice. Could you comment on how you did it and what worked and what didn't?
Okay, so first of all, the role of co-design in Living It Up's development was critical. And was actually central from the very beginning. And, you know, we all talk about putting the citizen first, the customer or the patient first. This was actually living that and doing that from day one. And even now, when I sit in meetings 4 years on, there is still that legacy from the very beginning of Dallas right through to where we are now with Living It Up, that is putting co-design at the centre of it. So the role was absolutely critical. And how it was done was very novel, and actually that was facilitated and instigated by the sandpit that was referred to on the film. And Living It Up actually engaged the services of Glasgow School of Art to come up with something highly innovative, highly engaging, that wasn't just research-based, but clearly had some evidence base to it, and developed various strategies across Scotland and engaged nearly 3,000 people in the co-design of Living It Up. So essentially, citizens were telling the NHS 24, about what they wanted, how they wanted it, when they wanted it, and what kinds of digital devices they would feel comfortable using. We knew we didn't want to leap too far forwards from where the technology comfort zone was of the citizens we were wanting to help.
Okay. Maybe moving on to Dave, just briefly, so a lot of people might challenge the idea of co-design in the statutory sector, specifically in the NHS, and especially at scale. So it's hard to do it well, but what were the drawbacks? What was the challenges, and how did you overcome some of them? What's the way to do this?
Okay, I'll hold it up so you can hear.
Everybody's holding it up.
Is that better? Okay, so I think sometimes we look at co-design as a very neat process, and it's not. I think if you want to co-design and you want to make a difference and you want to do things at scale, it's actually a very dirty, ugly process. And it's not this nice, we'll do a focus group, we write a nice report and everybody believes what we say. It actually, co-design for us ended up being, actually we need to know, A, what people think on the ground. What do citizens want? What do our users want? Then you've got to try and challenge the views of the commissioners to convince them that actually what they know and have known for a long time is not necessarily what the people believe. and sometimes they can converge but come from two different angles, and actually the way that you actually describe that is different. And then finally you've got your clinical pathways, and you saw Dr. Bowers there, who was our champion, about keep banging on about the clinical pathways, because actually when you talk about scale, otherwise you do projects, and if you want to do scale you've got to change the business as usual role, which comes down to the actual pathways that people on the ground do day in, day out. And that's where it's actually co-design becomes a real challenge. It's a real difficulty because you can look at it and it's in the textbooks and all the other things like that, and it's very nice processes, it's very neat, and we talk about service design, but the truth that sits behind it, when you've got to deliver it, it's very, very compartmentalised, and you can't do it all in one nice little focus group with everybody around the table and think that that's going to change anything. It's actually about that dogged approach of, we now know what the situation is, we understand your perspective, and now we've got to drive this through, and it takes time. And I think that's a big lesson there, is that, you know, even though you know the right thing to do, you've got a big, big journey ahead of you in doing it.
Okay. Yeah, Hazel?
I think this one probably is aimed at Lindsay, really. Can you have too much co-design? Can you do too much?
I'm going to say no. I don't think there's too much co-design that you can take forwards. However, what your co-design approach should do is change in line with your development stage of your programme. So, for instance, now we've got active users, and we've got 55,000 members in Living It Up, and that's growing week on week with active users of the site, i.e. those people who are returning more than 3 times a month. And essentially what our co-design now needs to do is actually change. So instead of going out into the community, we now need to engage the active users and members of Living It Up digitally. So whilst we did it face-to-face initially, co-design, and as Dave says, it took time, lots of it, now we've got the opportunity, I guess, to start using exploring how digital co-design can take place.
Could I just follow that up then with, for the audience, a time frame that this co-design piece took?
Doesn't stop.
It doesn't stop, does it? Honestly, I think it kicked off about month 4, and I think it finished around month 14. Again, once version 1 of Living It Up, was launched, there was then more co-design to be done for version 2, and so on. And it happened again with version 3 for usability testing. So there's, co-design can take place at different levels of your program. What would you say, Dave?
I'd agree. I think it's a constant process, and I think again, what you find in reality is not what you would like it to be. So you'd quite like to see co-design being, that's what it should now look like. Let's go and do that. But the truth that sits behind that is actually what you end up doing is taking a service on a journey of little bits of change all the way along to hopefully get to what you want it to look like. I think in answer to your question though, Hazel, I think the mistake you can make, and we came close plenty of times, and maybe even crossed the line now and then, was that you can get confused that co-design is a means to an end. Where actually you think what you're doing, your role is to co-design, whereas actually what you're trying to do is get to a particular outcome, and co-design is one of the tools you use to get there.
Do you think, does co-design eventually turn into evaluation? I mean, if you have users, citizens actively involved in helping you design these services, how important is it to keep them engaged and revisit with them whether things are working with them? I think Lindsay said something about it being an ongoing process, and you've just backed that up. So does co-design merge into evaluation? How do they relate to each other?
I'm not sure if it evolves into what you would think of as evaluation, but for most digital services outside healthcare, absolutely. So you move into the analytics and behavioural insights that you get from your active users, which is where you guys essentially are. I think one of the other things about co-design, sitting from the kind of design side of the business rather than the healthcare side of the business, is that co-design is really helpful for statutory sector organisations to create engaging services. And one of the things that healthcare providers in the UK are not used to as an objective is engaging people in their services, because their main concern, as we heard earlier on today, is beating back demand. So the idea that but if we want people to do behaviour change, if we want people to self-care, if we want people to do things differently, we need them to actually, we need to engage them in language that they understand. Co-design's really useful, I think, for shifting the mindset and providing, as Dave says, the tools then and the evidence to go and shift the commissioner's mindset to say, yes, you might want it to be like that, but if we want these outcomes, this is the way that the punters think about it.
So, Dave, you mentioned scale a couple of times, and I know scale comes out in the film, and it's been a huge part of Dallas to scale up and mainstream a lot of these technologies and a lot of the services. So co-design, let's be controversial, sounds like it might be in conflict with getting things out there really quickly and scaling up really quickly. How did you manage to balance that? Maybe Andrew and then John, how do you balance scaling up and mainstreaming what we've already got and then creating brand new innovative products? Where's the balance there, and how did Dallas achieve that?
So here I do think there's possibly a crossover with evaluation, which is we've got to get used to this being a dynamic. So just that we need ways of evaluating processes that can cope with rapid change. So we don't wait for a year to find out whether something works, because if you're putting up a digital service, you might know within 3 days that it doesn't work. So you're not going to wait for the other 362 days before you fix it. And I think that's true with co-design. So you can use these design processes, these design techniques, sometimes in very small ways and very quickly, and then get it out there. So the stuff that we did with in primary care with Vitality now, confusingly Modality, a big GP practice in Birmingham. We did the initial design process with the users and with the GPs. That took about 12 weeks. We then went live. And we went live with one practice, and then we went live with another practice, and then we're continually revising it. So it doesn't have to be a massive engagement. You can get out there quite quickly. I don't think there's a conflict with scale. And I think if you don't do it, there's a conflict with success.
Yeah. John, I mean, would you agree with that? Like, as a business, how important is it to get things out quickly so that you can see what's working and what's not working? What would be your take on that?
I would agree with Andrew, and I think that there's certainly a way of not getting scale is to design something that no one wants. And so it's really important to spend the time up front and actually and not impose preconceptions as to what products will actually fit. But equally, as a small business, there's an urgency about getting things out there and learning quickly. So it's about learning quickly and continuing to learn. And from a business point of view, it's also about understanding that whatever we put out is not the end product. It is the next version of the product. And actually planning, as a commercial person, planning resourcing, ongoing resourcing to make that possible. So just to get to the end of a 1.0 product, drop it out there and wait for all the sales to come in, it just doesn't work that way. It's a long, long haul. And I like them particularly, and it is learning, particularly with digital, is making use of the fact that we've got those continuous stream of information coming back from the system and learning from it and adapting.
Yeah. So I'll maybe pull in Frances and Karl just briefly. It seems like we're jumping ahead to evaluation, but people have mentioned that throughout. So if there are lots of different services, some technology, some not, and rolled out to lots of different people in lots of different areas, and scaling up quickly, how much of a challenge is that to evaluate? I mean, how did you approach that? Was there a different approach to evaluation that you had to take?
Yeah, I think it's totally different from the classical type of evaluation that academic researchers do, thinking about clinical trials where you've got a fixed service, a fixed intervention that can't be changed, it's totally inflexible, and you've got fixed outcome measures. And in a sense, as you were saying, if something doesn't work after 3 days, actually you're committed to following it up for 3 months, 6 months, however long, and it has to work that way. And clearly, Dallas wasn't about a single intervention. It was about transforming health and well-being and seeing what worked and what didn't work and discarding the things that were less successful and running with those that did. So our evaluation focused much more on looking at the whole ecosystem in terms of the public who were involved, the professionals, caregivers, industry, the market, the voluntary sector, all of those different players in the program, and seeing what was the things that promoted success in some areas and what were the barriers, where were the problems, because there were lots of difficulties, it wasn't a smooth journey, and I think the important thing for evaluation is to learn from that, to capture, well, what are the lessons from how the communities circumnavigated that, which in fact they did very successfully, but they had all sorts of stormy waters to negotiate, sometimes companies going bankrupt, partners withdrawing, and how you manage to carry on in the face of that adversity, what strategies worked, and what were insurmountable type barriers that you have to kind of circumnavigate.
Yes, and I'd echo what Frances said, really. I mean, I think if you've got a non-traditional program design, you can't have a traditional evaluation either. So it's about trying to evolve the evaluation design in parallel with the evolution of what the communities are doing. It was interesting from our perspective because our role was particularly looking at potential impacts of Dallas on the market and on wealth creation specifically. And the process that we followed was to engage with the communities periodically to see how things were going, and then to try to understand where those impacts might be arising. And what was really interesting for us is that every time we came to have those discussions, the communities had moved on in their thinking. There were new products, new services, new ways of delivering those things that have perhaps met a little bit of a dead end, and they were exploring different avenues. And so I think that was one of the critical challenges to us as evaluators, was to keep pace with that. And a randomized control trial type model, or something where you try and design in advance what you're going to do, doesn't really work if what you're doing is changing.
Okay. So I have a whole stack of cards I could go on forever, but I invited audience participation. You all have popcorn and you're all being very quiet. Oh, a hand up already, brilliant. So there's somebody in the middle, there's quite a few hands. So if we try to keep roughly to the themes we've been talking about, because there are other ones coming up, but if you get anything to ask to the panel, then now's the time to go for it. If you've got the microphone, please say who you are first of all, if that's okay, and then who you're directing the question to, that would help.
Thanks. My name is Sean McDougall. I was the monitoring officer for the MI programme, and I'm just returning to this theme of co-design. Co-design initially was a drive for designers to stop working on their own and start working alongside the consumers and end users of their products. Today, particularly in the public sector, co-design is used as a term that's applied to groups of people, but there are no designers present in that group. And so I'd like to ask the panel as a whole what you have learnt in relation to the involvement of professional designers in the design of future public services.
Should we start with Andrew or Dave? Yeah. Who wants to answer that one? Everybody's looking.
Do you want me to start?
Yeah,
I
think
Dave.
you start, Dave. Yeah.
I think that's a good question.
It is. It's something that we, and I'm sure Sean picked up on, that we struggled with at first, actually. Because when you're going through that design process, we kind of start off with this mantra that everybody can design. Ask people the right question and you can start to come to that design, and, well, we were wrong.
Do designers ever know best? Is there ever a case where you actually shouldn't waste your time and money on co-design, and you should just get a...
So the interesting one...
No,
sorry.
This is good. We're going to have an you can come in a minute. But my point being is that designers aren't necessarily always there to actually do the designing. It's the process through which you interpret the information that's coming back and how that turns into a design, and how you pull in different elements of professionals and how that fits into a pathway. That's the really hard bit, and that's where you require the professional skills that are required to do that. Just asking a bunch of people questions and sticking post-it notes on a wall will not get you to the answers that you need to get to. And I think that's where we kind of started asking some of those general questions. But unless you have the right structure around it and the skills necessary to turn that into something that can actually be delivered, then you struggle.
Yeah, I think that's a good point. Yeah, Andrew, did you want to add to that?
I think there's a couple of things to say about co-design. I think the underlying Sean's question is there a bad form of co-design that's been adopted in the public sector? And I think the answer is yes. And that consists of public sector organisations going out and asking the punters what they want, as if they hadn't got any responsibility for the services they're trying to deliver. So I don't think that's what happened in Dallas. But do you see that elsewhere in the public sector? Do you see service design companies getting decent fees off pandering to that? Yeah, absolutely. It does happen. But you also asked, is there a point where you shouldn't listen? So one of the things that we often do, and I've worked with public sector organisations outside health for a long time, is you ask them, at the start of when you're working with them as a designer, you start to ask them what do they aspire to, what do they think of their brands. And they normally mention two names. They mention John Lewis and Apple. So they obviously like white, is what you learn from that. But you said to them, do you really like Apple? Or do you want to co-design? Do you want to go down the co-design route and find out what your citizens want? Because there's one thing about Apple's design process: they don't ask anybody anything. So the aspiration that you might have, you might want to might not be appropriate for those kind of things. So there are people who don't co-design, and they create great products that we all love to use.
Yeah, okay. So we've got time for another couple of questions. Gentleman in the middle, you had your hand up straight away. It must be a good one.
Yeah, let's hope so. Alan Kennedy from Crawley CCT. I'd like to ask the panel a question about how this work is tackling the link between digital exclusion and social exclusion, which we know there's a very strong evidence base will lead to poorer health and well-being. And you've only got to look at the recent ONS figures and Tyndall Institute to understand there's something like, as I understand it, 6 million people who've never been on the internet. Something like 4 million people living in social housing that haven't got access to the internet. And the notion that we can use digital services to provide a wider reach to co-design makes sense. But by doing so, how is this program tackling the issue of involving those people that don't yet have access to that to those range of online services?
Thank you. Great question. So, Dave, you're getting picked on because you're right next to me, but I'll start with Dave and then we'll maybe go to Frances as well. But how would you answer that? Because that comes up a lot of times, especially when we're trying to promote the use of digitally enhanced services. So, what would you say to that?
It's quite right, and I think you'd have a serious problem saying you did any co-design or any communications with the public and then didn't think that was an issue. We found that out very early on in the programme, and our solution to that was to actually provide services for people to access the internet. And coming from a health or a social care point of view, that's not really your remit. And that was some of the sort of transition that we had to make in delivering this programme and why it was important to have a wide variety of partners. So we provided digital hubs and people in those digital hubs that could actually train and coach people to actually access the internet. And interestingly enough, those
like
people,
champions that were kind of
digital champions and community champions who were all there able to signpost people to and providing internet access and equipment to access the internet on. And interestingly, a lot of the results that we found is that we were finding that people were actually going online to apply for jobs. And it wasn't necessarily to access all of the services that we provided them. We kind of had a bit of a soul searching there. I think, well, is that a bad thing? No. Of course it isn't, because actually employment, wealth, all leads to better health outcomes. So actually, you're just coming a bit further downstream. So providing that access is there. We're also now moving on and working with our social housing providers to look at how they will, because the one thing we don't like about our hubs that we provide at the moment is it's a bit of a Victorian bathhouse kind of approach to the internet, and really the internet is the genius behind it is everybody can access it on their own in their own privacy at whatever time of the day they want to, and that's what's great about digital services. If you're going to provide them in a fixed station, then that's not ideal. So the next stage for us there is actually to work with particularly starting with our social care housing, where they're looking at models where actually you don't pay for the internet. It's more of a sponsored thing. So actually, if you click on that link to go and search through that particular search engine, then you get so many points and you group them together in communities, and that actually pays for the internet of that entire community and access on an individual basis. So there are models out there and we are working on it. So we started off with making sure everybody could access the internet and had access and training to do it. Now we're moving to what we think is a much better model, which is where everybody has their own internet access. And it links to everything, education, health and everything else, about how that family unit uses the new resources on the internet. And that's vitally important to us and how we go forward.
Okay, Frances, I know you would have something to add as a practicing GP and somebody who's evaluated telecare in reality for a long time. What would you add to that about digital inclusion, or what's your take on that?
I think this is a very real issue. I've always worked in practices which are located in more deprived areas. So when I hear some practitioners talk about patients bringing lots of lists of things to them on the internet, and I'll say that's not necessarily my experience, because sometimes I'll direct people to internet sites and apps and find that they kind of look at me as if I've gone mad, that I should be thinking of such a thing, and they don't have access to that. I think one of the things that struck me about Dallas, I thought was a really strong learning point, was the effort that the communities went to, for instance, in Liverpool Mine and Living Up, and these to look to with digital champions and these efforts to engage and upskill. And I think the information we've gotten in terms of socio-demographics of some of the people participating in the Dallas programme has actually shown that they successfully managed to get people from across the socio-demographic spectrum in terms of deprivation levels. But that was not easy or straightforward, and I think the challenge that's faced was made visible through the Dallas programme. I think that's one of the things we'd say, that if you just throw out those services and new technologies and opportunities, you really need to also throw out efforts to engage, upskill, and enable people to be able to grasp those opportunities. And I think that's a key point.
Okay. John, you got something really quickly to add? We're getting signal that we're going to have another little snippet of film. Do you want to add something really briefly?
Just
and then
very
we'll go into
quickly
the next
on
one?
the digital exclusion is that with one of the services that we produce, PainSense, we started providing devices in community health provider premises, and which has been very successful. But one of the things that surfaced was that some of the providers themselves are not particularly digitally enabled, and so just that it's not just the service users; it's actually the service providers often don't have Wi-Fi, don't have the skills, and so that is quite probably a shorter term obstacle, but it's a very real obstacle for getting mainstream.
Okay, so you mentioned PainSense. I'm going to take advantage of that. One of the things that comes up a lot is there are lots and lots and lots of apps for health and wellness and lifestyle. And there's a lot of kind of uncertainty around, which ones are medical devices, which ones are lifestyle apps, and should there be, guidelines and policies or accreditation processes around that. And I know that throughout the communities you've been involved in some work about understanding what we might need to do there. Have you got anything you could add that we've learned through Dallas about whether apps need to be accredited in this space or whether that would stifle innovation? What's your thoughts on that?
So we've done a lot of work on this within iFocus and in the body that's taking the Dallas work forward, DACA. At the moment, there is a situation where there are literally hundreds of thousands of apps out there claiming to have health and well-being benefits. The vast majority of them are not trusted by healthcare professionals and don't connect into services and don't connect into the informatics systems used by professionals. And so we see that as being a key enabler is actually to build processes for assessing, endorsing and integrating apps into professional systems. That does not mean that we think that all apps need a single process of certification. Clearly they don't, but we think that we're working with the NHS and the National Information Board to work out a fit-for-purpose process for maximising the number of apps that will be available that can be trusted and can integrate into statutory systems.
Okay, brilliant. I think that will probably come up again. I'm just going to go to one more question in the audience and then we can come back to Lindsay. Or the film, depending on what signal we get. But is there another question? So we can't see you very well, but if you could say who you are and what the question is.
It's Jackie Marshall Cyrus from Innovate UK. I'd like to take the discussion back to the theme issue, really, which was the 6 C's. And as John pointed out in the film, interoperability was seen as one of the key barriers. The second key barrier and key theme around Dallas was lifestyle and recognizing people's lifestyles as a significant contributor to this whole agenda. And as one of the lead architects around the 6 C's, I would be interested in trying to extrapolate, because I always saw it as that, not only as part and parcel of the development of the Dallas projects, Dallas communities and what Dallas had to deliver, but as a key component of getting the Dallas projects together to build capacity and capability. And how did that coalesce among the 4 Dallas communities? How did that drive collaboration between yourselves? How did that build a sense of community? How did you contribute to each other's agenda, as well as what that means for scalability? So what do the components of the 6 C's actually mean in terms of scalability of what you've developed and intend to deliver?
Okay. That felt like a couple of questions, but going back to the 6 C's. So if I've understood correctly, so how did it translate? Like what actually happened in reality? Working both as a community on your own, but the cross-learning, that was at least part of the question there. So John, starting with you maybe, how do you think the 6 C's translate in reality to help you to deliver services? They started as a concept, but what do they translate into? How do they help you or hinder you?
The collaboration was at the heart of Dallas from our point of view, and I think that what we started off with a focus on interoperability, and as an assumption that was really about technical issues, but actually the main problems in interoperability are not technical. They are about negotiations between people, agreements between people, collaboration, mutual understandings, and so that collaboration first with the Dallas communities and then more widely within DACA has been absolutely. It is how do we find a common cause? Because if we're actually going to create a community or create some kind of common endeavour to transform services, we need to agree on a common cause. And if without that, then we'll pay lip service to it, but we won't actually work together. So it's that it's collaboration at depth, I think. Collaboration like you actually mean it was really important.
Yeah, so Dave and possibly Lindsay as well, so how did that translate into what you were doing? I'm sure there were plenty of barriers given the size and the complex nature of the consortium you were working in. There was the healthcare sector, social care, voluntary sector, digital design agencies. How did you battle through that coherence stage to get everybody on the same page and to actually enact that? I'm sure there must have been stumbling blocks. Can you maybe give an example of what you came up against and how you sort of circumnavigated it, if you managed to?
I don't think we circumnavigated it at all. I think the whole point was to tackle it head on. I think what we decided to do in the end is that we ran this project with joint ownership. So actually, although we were at CCG, we were the main lead for the project and a large organisation, both in terms of commissioning things. When it came round to that board and and all the partners that sat round, everybody had an equal voice. And it doesn't matter if you were a tiny little voluntary sector organisation, you were there with a voice and you had just as much ability to shape what was going to happen as all of the big organisations, including the local authority around the table. And that's what made it different, actually. And that's how we started to really get a different approach. And all the other elements that Jackie was referring to then came from that. And it's been quite interesting from our partners in the discussions since we since we left the programme and kind of started to wrap it up. We've looked at, well, okay, where do we go from here? What's the next step for us? And we've been having those discussions as we've moved on to the next phase of what this has brought about. And what we found is that all of our partners say we want to carry on that approach, actually, because we feel like we've got a seat at the top table here and we like it. And we're getting to say, well, actually, my opinion counts here, and we all get to shape how that works. And I think that, for us, was one of the big differences, and that actually stemmed right from the whole Innovate UK approach right at the beginning, where we all got brought together in one place. And even though we had to go through a contracting phase and everything, and Mike's smiling at me now because, put your hand up and say it's my fault if it goes wrong. But at the end of the day, it was a case of, okay, we're the lead partner, but everybody else has that equal say around the table. And we found that to be, in terms of community collaboration and all the other elements, all the other 60, it stemmed from there, because your community and your voluntary sector bring their thoughts and their people and their volunteers with it. We brought our professionals, and all that came together. But if you've not got one overarching voice over the top of everything, you've got to find a solution that will work across everybody's considerations around that room. And for us, that was different, and it was really hard. Because actually, when you work in big organisations, you used to go, nah.
Yeah.
But actually, you couldn't do that.
Okay, we're going to come back to this. I'm just conscious that the film is working and I don't want it to stop working, so we'll come back to that exact theme. That comes back up in the questions later on. So what we're going to do now is take a second look at the second part of the film, and to see what were some of the outputs or the impacts that were realised across the communities, revisiting some of the things that Jackie brought up about what was the learning, both individually within the communities, but what has reached outside across the communities, and what can you learn from what the Dallas programme has achieved. So let's take a look at the second film, hopefully.
So, what would the Dallas projects themselves say are their greatest achievements and most significant impacts? The answers come in 3 areas. Innovations that have shown how to do things differently, tangible and measurable impacts on healthcare outcomes, and benefits from industry healthcare partnerships that will create economic growth. I think within the Year Zero programme, probably the greatest innovation was something that actually you could describe as a building block rather than a complete service. By working with Dame Fiona Calder-Cartman and NHS England with the HSCIC to produce guidance that recognises that there is clinical data and there is personal health data, and by establishing the rules by which these can interact, we've done something that's widely applicable for other innovators to take forward.
One of the great successes that I supported was the House of Memories app. It was driven by our museum. It was designed by one of our local SMEs, where they had to truly understand what it meant for them to live with dementia and how that app could truly support what they did. And that really was fundamentally what was behind its success, because it was an app designed by those people for people living with dementia.
Key innovations for me, because I'm the community guy, have been around the innovations that have been people and community driven. So the mobilisation of our third sector partners to bring online 50 digital hubs, coordinated by the TUC and their learning branch, which have recruited over 300 volunteer digital champions, which have trained over 4,000 citizens and turned 4,000 citizens on to digital and being online. Great innovation.
Living It Up is a real live service. You know, it's out there, it's working. There are digital tools already on it, people are engaging with it. We've got 40,000 to 50,000 page views a month that's happening in Living It Up. We've got 19,000 people who've registered because they're interested in it and participating. So for me, innovation is no longer what we do, and we didn't actually engage with developing Living It Up because we wanted to innovate. What we were looking to do was to develop new services.
The history says that innovations take 17 years to be accepted by the NHS. And obviously we're trying very hard in the Digital Health and Care Alliance to reduce that time as much as we possibly can. There's no doubt that during the time that Dallas has been in operation, that people in the NHS have become much more aware of digital health. One of the issues, though, is the feeling now that all I need to do is to tender for and install some digital health, and the benefits will come flowing out of the ground. And actually what you need to do is to change the way you work.
But Dallas has been more than an innovation project. By responding to the challenges of deploying live services into the mainstream, the Dallas projects have seen significant impacts on health outcomes that could be repeated elsewhere.
We've got our GPs prescribing telecare. That's fundamentally different. And even we at the beginning of the programme never saw that coming. It wasn't actually in the original plan to go down that route.
I think the greatest claim we can have to having a measurable direct impact on people's lives probably at this stage comes from the work we did in primary care with the creation of this multi-channel digital access to GP services in Birmingham with the Vitality Partnership. So we put up a new model of accessing primary care via the web, via the telephone, via a mobile app, as your direct access to a doctor. And we've seen amongst that population a 20% decline in A&E attendance. And that's because they've got a primary care service now, enabled by this technology, that's responsive to them and gives them what they want. So they know they can rely on it, so they don't go to A&E.
So I think in terms of, healthcare benefits for Living It Up, what we're really looking at are behavioural changes in the individuals that are using the service. I think we're probably not looking at hard clinical outcomes necessarily in terms of, a reduction in somebody's high blood pressure or something like that. So the sorts of changes we're beginning to see are around people, sleeping better, being more active, being better connected to the people that love them and feeling more, able to speak to their doctor.
I was a fairly early adopter as the digital lead for the benefits of telehealth, but I think when the numbers came out, when we'd rolled it out to enough scale that we were able to look at some of the outcomes, and we started to quote a close to 20% reduction in hospital admission. Well, there isn't a drug that we prescribe that does that. There are very few interventions that the health service has ever been able to offer that can keep a fifth more people out of hospital instantly. That gets you thinking. Well, okay, we've done it for 2,000 people. What if we did it for 10,000 people? And that, for me, was the key switch in the city's culture.
For all the Dallas communities, collaboration between health and care organisations and industry, large and small, has also given some early indicators of how the transition to digitally enabled health services could generate economic growth, locally and nationally.
Because Liverpool now is starting to be seen as a place that knows how to introduce digital technologies to its business and its operating model, we have interest of not just SMEs who are thinking about setting up business in Liverpool, but also some bigger companies that are thinking differently about where their R&D base should be.
The last 3 or 4 years, we would say, have seen a dramatic progress towards a real market where people understand how to commission, specify, integrate, deploy, support digital technologies, which for us is great news. It means it's moved it from something which clearly had massive potential, the use of digital technologies in health and care, but it's moved it from the sort of early on the hype curve to where we think it is now, which is at the bottom of the ramp to real commercial exploitation, where it becomes a commonplace.
The contribution of SMEs has been absolutely at the heart of Year Zero, because taking the approach we did, which was the development of products, they were each led by the SME that was behind them, and each of them took the approach of it as a business proposition, basically, that we're going to develop a product that we ultimately want to have buyers for. So it wasn't just a concept. It wasn't looking at it as a proof of concept, let's see if this would work.
Health innovation is now written into the City Region Economic Growth Plan. There is European money's been focused into health innovation, and as somebody who's worked in the city for a long time now, it's been really difficult to get the economic regen guys turned on to health. Dallas has helped us to do that.
So after 3 years and engaging more than 150,000 users, what advice would the Dallas community offer to anyone wanting to embark on their own digital journey? And what issues has the evaluation identified that could trip them up?
I think Liverpool is completely signed up. Our governing body has agreed £15 million over 2 or 3 years to support this. It's the second biggest investment in Healthy Liverpool will be for this digital programme. So from that point of view, Liverpool as a city is convinced. I think that our patients are starting to see the benefit. I think in terms of the whole country, in terms of the message centrally, my best advice and what I would love to dearly see happen is for them to just allow local organisations to do what's right for local populations. Give them the freedom to innovate differently, because the solutions for Chichester aren't going to match the solutions for Liverpool.
There's a big issue in terms of readiness for digital health technology. If we're wanting to make it ubiquitous, then we need to think about it at macro, meso and micro levels. And when I'm talking about macro levels, I'm talking about what's the market readiness, what's the policy and legislation readiness. When I'm thinking about meso levels, it's thinking about what's the organisational readiness in health services, social care services, industry. What's the technical readiness there for in terms of our ability to roll out these kinds of services? And then at the micro level, thinking about patients, the public, consumers, caregivers, and also professionals. What are the barriers and facilitators? What are their readiness issues?
Find the clinical champions and work with them. Find the expert patient groups, the people who will actually bring the service user's point of view to the table. Work with them. Find the local innovators, the SMEs such as ourselves and other organisations who've worked in a similar way within Dallas. Work with them and together work out a programme of change that's led by the ambition for the service, that's led by the best clinical guidance, that's led by what service users actually want, and that's facilitated by creative, innovative, fast-moving SMEs. That's a recipe for successful transformation that we've found within Dallas.
So what's the right model? Is it to direct services and products at consumers? Are they ready for off-the-shelf stuff and downloading apps on their own? Or do we need a model where GPs prescribe kit and apps, or is there a place for both? both of those models? Lindsay's nodding, so I'm going to go to you first.
I would definitely say it's your last comment. There is a place for both, for practitioners to help consumers and consumers to drive change and push services further into the places where they feel they can better self-care and self-manage. I mean, we talked a lot about replicability, creating the models that then, you know, can be put across different health boards. From a Living It Up perspective, that had to be built in from day one. There was 5 health boards involved. There's now 7. But from day one, there had to be the idea that what worked in one area of the service then had to be working in different areas for different areas. And clearly in Scotland, we've got island communities, rural communities, as well as urban communities. So we had to take all of that into account. And I think in terms of the control, choice, collaboration, coming back to the 6 C's idea, that without you know, building in the, you know, what John said there on the film, without building in all the expertise from the different collaborators, there is really no way we would have had a Living It Up service like that exists today. And, you know, despite the rocky waters that Frances was saying earlier, we did have partners drop out. There were, you know, it was a result of the economic downturn, but our largest partners, O2 Health and Vodafone Health, dropped out of the collaboration. We had to adapt, we had to be nimble, we had to rest upon smaller SME expertise and find it from elsewhere within the collaborative group. So the partnership, as much as it was difficult to navigate, we also pulled together really and developed the models that could then ensure the service was fit for purpose but also replicable across the organisational structure that we had to work with.
Mm-hmm. So do people trust the lifestyle apps that are out in the consumer market, or do they want that from their doctors? Like how ready is that market?
Okay, so I think that's a bit of a red herring.
Okay.
I'll be controversial.
Yeah, go for it. And you could rely on controversial.
The one thing that won't work is any form of digital interface with the citizen that the service doesn't believe in.
Mm-hmm.
So whatever it is, whether it's a lifestyle app or whatever it is, users of the NHS have to know that it's the right thing to do, that their clinicians think it's the right thing to do for them, they endorse it and welcome it, and if that means they are more engaged, they then have to be able to cope with the response of that. So I don't think there's this huge division. I think one of the things that we found out in Dallas, one of the things that didn't work for us is, at the start we imagined with the Red Book that what we do is pursue one deep, and Dan, anybody who wants to talk about the Red Book, Dan Moulin from Psychic is here today. One thing we thought we'd do is that Psychic will produce this clinical app that would be the professional, fully connected, fully working thing, but we would also go direct to consumers, to mums, because we knew the audience, we did the audience research, we had lots of brand partnerships, blah, 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 blah. That didn't work. It's impossible at the early stage to bring that off because the level of trust between the Royal Colleges and the direct consumer market just isn't there. But when we did this thing with that worked incredibly fast towards the end of the project with GPs, which was, I mean, from a digital point of view, it's dumb. It's 10-year-old stuff. Multi-channel access, same as any retailer does. Fine, contact us any way you want. What that was a primary care organisation who wanted to treat their patients like customers. So actually, what we found out was the thing that really works is, if you want to talk about a consumer, is bringing consumer approaches to the mainstream business of the NHS. That really worked for us.
I'm going to bring John in because he's been nodding.
Sorry,
I'm assuming in agreement. So John, what would you add to that? Are you agreeing? What would you?
I think one of the things that's a key learning from Dallas is that in fact there are hundreds of thousands of freestanding apps right now. But really, to get the value from those, it is finding ways to connect them into service and to provide the trust. So what we're doing with PainSense, the service that we're rolling out across Leeds, is absolutely, it needs to work for the professionals, and we need to build the awareness with the commissioners and the physiotherapists and the people who are involved in managing chronic pain. But what we're starting to do also is to run radio ads in the city, and just to build awareness that for people with chronic pain, that there are actually tools out there which are available on the NHS within Leeds, that they can request from their GP that can support self-management and give them control. So we are, that's with the agreement of the CCG, that we are starting a radio campaign actually in that area. So the results aren't in yet, but we think that actually raising awareness and getting acceptability on all sides of that multi-sided proposition is absolutely crucial.
Okay, perfect. I'd like to thank Frances in, just because a lot of times health professionals get accused of not being ready for, you know, the technology. It's too fast-paced, and consumers are ready, but health professionals aren't. Could you comment briefly on that? And I don't know if Dave might want to add something on that as well.
I think health professionals are by nature risk-averse, because we live in a especially increasingly litigious society, and so therefore, you know, we're not wanting to be prescribing, and also patient safety is our priority. So we're not wanting to be prescribing apps that we think that actually they might be unhelpful. And then there was a paper in BMC Medicine just in the last few months which was showing that some of the diabetes apps were actually giving advice that would be harmful. And equally, there have been some other studies that have been in the literature just recently talking about the security and data encryption again apps. So, you know, we don't want to be recommending things to people where we think they're going to put them at risk, their data. So we do need some kind of way that say, not necessarily you need a randomized controlled trial for every app that's there, but something that says, well, actually the information that's in that app is actually correct. It's giving the right advice, it's not going to do any harm. I think that's a big issue for health professionals before we're going to be you know, very happy to say to prescribe them.
Dave, do you want to add something about that? Or?
I think it's dangerous to group people too much. We call everybody health professionals or social care professionals. We're all human beings, and we all in different society pick things up at different paces. You will always have the fast adopters and the laggards in any profession. And I think what we tended to find is actually you've got to find those in the profession who are prepared to actually stand up and argue your corner. You saw on the video there that Simon, he will stand up in front of other GPs and he will say, this works for me. And next month my ACS admissions are going to be down and yours aren't, so ha. Okay, and all of a sudden it's like, oh, hang on. That's a different argument. And we're not talking about evidence-based anymore, we've proved that. Now we're going from peer to peer, and they're going to argue the fact that actually it works for me, I've done it. What's your excuse? And it's actually that very human interaction of why aren't you doing it? And you can't hide behind your profession because it's peer to peer. You know, we went around a number of different GP practices and different elements, and I can't argue with the clinician. Don't have the skills or the knowledge to do it. But those clinicians who are looking at it, working on it with us, can do that. And they can turn around and go, no, sorry, I don't accept your argument, it's not right. Because I've done it and I've implemented it, and that's how it works. And for me, you've got to approach every single one like that. I don't think you can just say, do you know what, we've done this for 3 years and there's the answer. It's no different than adopting many, many other different things. You've actually got to find the ones who are going to support you and then grow it from there.
So let's throw this back out to the audience. The audience are very quiet, and I did say we wanted some, oh great, hands are going up. So around the themes we've been talking about, or ones you've heard before, we are going to run out of time, so let's get some questions in from the audience. Be as controversial as you like. Say who you are, please, and who you're directing it at.
Hello, Jonathan Butters from Moro Limited. Obviously the home is becoming a key part of the digital and physical health infrastructure. Is Dallas at the Ideal Home exhibition next year?
Interesting. Yeah, well, should we direct that at Hazel first? I don't know.
Yeah. That's a really interesting point, thank you. At the moment, no. Absolutely. Good question. Why not? Yeah. Thank you.
Yeah, I think that's a great point. Anybody else? There must be more questions, more controversies, and so we have one, yep, just down here, and then there's, oh, Marian's already there, perfect. We'll take those two questions.
Hi, Anthony Riggs from TTP. I'm loving lots of the things that I'm hearing.
but these figures of 20% and this GP are not being delivered in a way that I can quote or take away. So when are we going to get the written material, presentations on the website with attributable quotes, pointing at which community, naming the person making the quote, giving the sample sizes? I was kind of hoping to get that information today.
Yeah, that great question. So I think there's probably several answers to that. Certainly, John, do you want to say something just to reiterate about the DACA website, and then Hazel maybe say something about additional reports? So.
Yeah, so the DACA, the Digital Health and Care Alliance organisation, is continuing to take forward Dallas, and so we'll be publishing results and evaluations on there. So it's free to join, so it's open to join. So join DACA will be the first thing, and that you'll get updated all the information coming out of the Dallas communities as they continue. And there is quite a lot of information behind the headlines we've given today.
Okay. Do you want to add something from Innovate UK's point of view, Hazel?
Dallas has generated a massive amount of collateral. There really is something in there for everybody, and as John said, that's going to be under the DACA website going forward. We're releasing that on the 10th of December when we've completed all our road shows. And then as part of the Dallas programme, we had 2 formal evaluations, as mentioned earlier, from the University of Glasgow and from Databuild. Those reports are into Innovate, and we are processing internally with a view to getting them out probably early in the new year, because they're really significant, large, lots of data reports. I'm looking at Frances as I say that, so we need some time just to process those. But they'll be accessible, and you can use that to further your cause in this field.
Frances, you want to say something just briefly about, I know people will ask about evaluation outputs in terms of the more academic papers that would be citable, which I know will be forthcoming. Do you want to just briefly say something about that?
Yeah, on the booklet that you actually get today, for instance, there's a paper that we had out in the Journal of the American Medical Informatics Association in August of this year, which was talking about some of the key implementation lessons from that, and we will be also driving forward with more papers, one about readiness and also about the health economic component work that we did for Dallas. But I think an important point is about, for instance, the health economics analysis that we've done, is that a lot of the services were aimed, for instance, if you look at Living It Up at Well People, about enabling and volunteering and things like that. And of course, that's quite different from a lot of the traditional type health interventions where people have used the EQ5D and tried to measure how does health of somebody with heart failure changes over a period of time, and to get quality adjusted life years measures. And so our health economists have actually developed their economic analysis around the 6 C's, and trying to look at willingness to pay and valuing, seeing how the public has valued the 6 C's and how much they would be willing to pay for apps or services in that sense. So I think it will be a little bit different from the kind of traditional evaluation that will be coming up, and our economists are still churning away at that time, but we do have a report with Innovate.
And the Dallas has started off many services that are deployed, operational, and are continuing to be evaluated. And so as that information, the Pain Sense service in Leeds has got 750 connected users, and we're starting to see significant impact on a reduction in referrals to secondary care for people with chronic pain. That kind of data will roll on, and these are not projects. These are rolled into operational services, and so that as that data hardens up and becomes evaluated, then it will be made available and as appropriate, and will be published on the DACA website.
So no evaluation, there is an evaluation slot just come up, so I'm conscious that I invited people to talk. So if you could maybe, Marian's pointing, if you just maybe squeeze in a quick question, you can make it difficult, but we're going to have to be really quick because we're going to have to wrap up shortly. So
okay. I'll be very quick. My name is Mark Dooman. I'm a patient, like many of us in the room. We saw the whole system demonstrator being published and poo-pooed by many clinicians. I think one of the challenges is actually not just about clinical changes and reduction of 20% in A&E, but how are we empowering patients? So to quote Warren earlier, if you look at Wanless, he talked about a £30 billion saving if you actually engage the public. Now that is the deficit we're currently looking to fix. Secondly, if you look at activated patients on a scale of 1 to 4, when you take a patient from level 1 to level 4, you have between an 8 to a 21% reduction in provider costs. So it's very nice that Beth Murray talked on the video about some of the soft stuff, but how do we put that into a figure that finance managers, in providers and in commissioners will say, hold on a minute, this activated engaged patient doesn't just make clinical sense, but it also makes financial sense, because sadly, that seems to be what's driving the whole system at the moment. So my question would be, in whatever we produce in Dallas, even if it's estimates, can we try and put some money beside it?
So actually that was a really clever question to ask right now, because in terms of timing, I think, am I correct in thinking we have to? So if the people who have the questions, especially that one, I think that's going to be addressed in the influencers panel, just coming up shortly. Plus, I'm sure the Dallas leads here would be more than happy to try and address that question. And I think it's more of a general point. I think you're absolutely spot on. What I would do is say, stay, eat your popcorn. We're going to have the influencers panel, which will continue with this theme.